Good morning. I'm Dr. Karen Greenberg. I'm one of the attending emergency medicine physicians here in South Jersey with UMD&J. I work with Virtua, Kennedy, and Capital Health Systems. And it's my pleasure to talk about infection in the elderly. We're actually going to be splitting this talk into two different pieces because it's such a broad topic. We could talk about infection in the elderly for a whole day probably, but I did my best that I could to condense it into two parts. This part will be the longer part, but we'll get through it, and then we'll take a break, and part two will be shorter. So this is talking about the care of aging medical patient in the emergency room, part of our camper program that we're offering. And again, this is infections in the elderly, part one. So what are our goals by the end of this hour? We want to be able to recognize and treat infections in the elderly patient because it can be particularly challenging. Their symptoms are often quite subtle and atypical. Your goals as an emergency medicine resident will be recognize common atypical presentations of various geriatric infections, institute treatment in the elderly with respect to medication dosing and drug interactions, identify admission criteria and appropriate transitioning of care from the emergency department. And we'll go into all these things in a lot of different detail. So we're going to start with some questions right off the bat. 82-year-old male presents from home with his wife. The patient is complaining of shaking chills and fever of 101 prior to arrival in the emergency department. The patient just finished a 10-day course of penicillin yesterday for a salivary gland infection. In the ED, his only complaint is left flank pain. Which of the following does not place the patient at increased risk for infection? I'll buzz you guys in here. History of sarcoid and taking prednisone, history of urostomy bag, daily exercise, decreased cough reflex, or malnutrition. Okay, so we're pretty much across the board there with C. Very good. Okay, question 2. 91-year-old female presents from a nursing home with change in mental status. Vital signs are temp 101.8, blood pressure 77/40, heart rate 85, respiratory rate 16, and pulse ox 92% on room air. The patient's niece tells you the patient hasn't been eating well, non-productive cough, Foley catheter in place for 2 months. Which of the following organisms is the least likely cause of infection in this patient? I'll let you guys log in here. Enterococcus UTI, enterovirus, Staph aureus pneumonia, strep pneumomeningitis, MRSA cellulitis. Okay, so we're a little bit, most people think B, a little bit C, D, and E, so we'll talk more about that. One more question for this part. 71-year-old male presents with confusion for the past 2 hours. For the patient's wife, he was complaining of chest pain at home and she called 911. Vital signs in the ED are as listed there. Of the following lab tests, which is associated with a greater mortality rate during hospitalization? Is it A, the white blood cell count of 15,000, the serum creatinine of 1.5, BUN 45, lipase 150, or lactate of 3.6? All right, so most people think E, a couple people with C and D. Okay, so let's talk about why infection in the elderly is really important and how you guys can relate to this, I'm sure. So by 2020, which really isn't that far away, patient age 65 years old and older will constitute 16.3% of the United States population. Already, they account for over 15 million emergency department visits each year, and a large percentage of these visits are related to the complaint of some type of infection. Fever is present in 10% of all elderly patients. They account for 65% of patients with sepsis. They're at significantly greater mortality risk for a given infection than our younger adults. So when you get your elderly patients with the complaint of fever and infection, your radar really has to go off that this is somebody who's sicker than your average younger healthy patient. They have 3 times the mortality from pneumonia and 5 to 10 times the mortality from urinary tract infection when compared with younger adults. And I think that's really important to consider because we're constantly diagnosing pneumonia and UTIs in the emergency department. And even if we're sending them back to nursing homes or you're sending them home, those are impressive statistics. 3 times mortality for pneumonia and 5 to 10 for UTI. It's not a benign thing in your 65 and older population. So because of these statistics, it's really important that we make appropriate evaluation and treatment an essential skill in our repertoire. The clinical presentation, when they do have infection, it's often atypical, it's subtle, it's elusive. And I think we know that. I think we know that these little 9-year-olds that come in with change in mental status, that you really have to go after that urine because it's always the hardest thing to get. Constantly, what's holding up your dispo on a patient? It's almost always the urine. You can get your chest x-ray, you can get your blood work back, but we have to go after it. So because everything's atypical, it's subtle, it's elusive, it makes early diagnosis and initiating treatment a challenge. Elderly may not only have fewer symptoms, but they might present with nonspecific consequences of infection that on the surface appear unrelated. And so what are some of those things? They come in and they're just tired. Maybe they fell. A lot of times that mechanical fall is related to something else, and if you don't go looking for it, you won't find it. I just took care of an elderly patient last week at Marlton. He sort of bounced back. He had fallen and hit his head on Coumadin. The ER doctor actually did blood work, did a CAT scan. He never did an EKG on the patient. And if he had done an EKG, he would have seen that the patient's heart rate was 40. How they didn't get that in the vital signs, I'm not quite sure. But they just always have, their fall is usually due to something else than a mechanical fall in the elderly. So have a higher suspicion to do urines, chest x-rays, blood works, EKGs. Change in mental status, we know about that one. Might just be a vague complaint like anorexia. The classical manifestation of infection, fever, and leukocytosis may be absent or blunted in 20 to 30% of serious elderly infections. So in contrast to your younger patients where fever is commonly attributed to a viral process, in the elderly it is associated with severe bacterial infections. So again, that was just one of the questions that we went through. Don't blame fever in the elderly on a virus. Okay, don't discharge elderly with viral diagnosis. Admit them, start them on antibiotics, let somebody else figure it out. After a 24 to 48 hour stay, if they can't find anything and they think it's viral, fine, but don't take the risk yourself. It's important to note that criteria for fevers in the elderly are unique and include elevations in body temperature from a baseline of 1.1 degrees Celsius or greater. Furthermore, hypothermia, a decrease in body temperature, is not an uncommon presentation of an underlying serious infection. And I think that's important too because we use these silly temporal thermometers in the ER now, and I'm really not a fan of those. They'll come up 97.5, and if you put your hands on the patient, they're burning up. And you do an oral temperature and it's 103. Or on the reverse side, it comes up maybe 98 or 99, and if you have your nurses do a rectal temperature, they're actually hypothermic. So I think it's important to make sure that you're doing accurate temperatures. What are the risk factors that make the elderly such a risky population? So just aging in general, they have numerous chronic illnesses and comorbid conditions. We know that about our nursing home patients, and they come with a med list that's 2 pages long. Polypharmacy and immunosuppressive medications are common. And then you get changes in your immune system that include a reduction in T cell function and cell-mediated immunity. You also see an impairment of the normal physiologic reserves. So you have a decreased cough reflex that can lead to aspiration pneumonia. You can have impaired arterial and venous circulation that lead to wounds and cellulitis. So the compromised wound healing makes cellulitis a common infection especially. Their living environments, such as assisted living facilities and nursing homes, allow for development of infection and foster the transmission of infectious agents. When we talk about the carbapenem-resistant Enterobacter, that's a very severe resistant bacterial infection that's only seen in nursing homes right now. So those facilities are contributing to the rise in exposure of antibiotic-resistant bacteria such as MRSA, VRE, and now the CRE. And that's important to keep in mind when you're going to choose your antibiotics. So once you make the diagnosis, then it's a two-step process. You want to make sure that you choose the right antibiotic. A lot of times they have invasive devices, indwelling urinary catheters, intravenous catheters, feeding tubes, tracheostomies. They're all more common in the elderly. They all compromise host defense, enabling bacteria to enter the body and cause infection. Malnutrition, common in the elderly population, especially your nursing home population. It's associated with a limited immune response and impaired wound healing. And then you have your polypharmacy that can contribute to infection just in itself. Okay, so we're going to try this question again now that we went through that. This is the 82-year-old, fever, 10-day course of penicillin. So which of the following does not place the patient at increased risk for infection? You guys did pretty good on this one. Oh, who hit the wrong button? All right. Good job. Good job. Way to pay attention. Way to stay awake. Daily exercise. Good job. Proud of you guys. All right. Fever and infection. Elevated temperature is one of the most common complaints in the elderly and is present in approximately 10% of elderly emergency department visits. When fever is present, it is infectious in etiology approximately 90% of the time. So it can be weird things like thyroid storm or maybe a weird cancer reaction. But when you hear the hoofbeats, don't think zebras, think the horses. Go after infection. Most commonly bacterial in origin. In several studies, it has been due to a viral cause in less than 5% of cases. We'll talk about influenza in part 2. Okay, obviously when it's flu season, it can be viral. Okay, but for the most part, bacterial, 95% of the time. A temperature greater than 100 degrees Fahrenheit is associated with markers of serious illness over 75% of the time, which means if they have that fever in the emergency department, they're going to have positive blood cultures, death within 1 month, the need for surgery or an invasive procedure, hospitalization for 4 or more days, the administration of IV antibiotics for 3 or more days, or a repeat ED visit within 72 hours. So these are things that are commonly associated in the elderly if they have that temperature in the emergency department. What should your workup include? A CBC with diff. Do your differential and look at it. Don't discharge people if it doesn't come back. Call the lab and look for it. We've had people go home from all the different emergency departments I work in. Their white count's 8, which is normal. Their bands come back at 20. Okay? Look at bands. Look at bandemia. Don't let, and even that goes for young people too, don't let them get out of your emergency department without that differential. Urinalysis, we know. Chest radiograph, we know. Blood cultures, urine cultures. The lactate's my favorite test. We're going to talk about that a little bit more in depth. Since I gave this talk a year ago, when I walk into the emergency department, they stock the gray tubes for lactates because I do them on everybody. It's elderly person, they're there for infection, they're there for abdominal pain, they're getting a lactate, they just know. And then we're going to talk about procalcitonin. I don't know if you guys get the emails, you guys probably do, from Condalucci, that this test is coming to Kennedy. So let's talk about lactate for a minute. In patients with infections, increasing serum lactate values greater than 2 were linearly associated with relative risk of mortality during hospitalization at 30 days and at 60 days when compared to patients with serum lactate levels of less than 2. So I just had a case at Marlton. I had this 90-year-old lady with abdominal pain. She had presented on Mother's Day just with nausea. The ER doctor did urine, he did labs. Everything was negative, he sent her home. She bounced back 2 days later, now with abdominal pain and nausea. My workup was negative, including a CAT scan, but her lactate came back at 3.4. So I admitted her, and the service gave me a hard time. They said, well, maybe that's just an error. Why don't you repeat it? And I said, no. I said, you repeat it. I said, she's getting admitted for observation. She can get fluid. She can get seen by a GI. But maybe she's got bacteremia. I think that it's a helpful test to consider. Greater magnitude of association with mortality than either of 2 other commonly ordered lab tests, leukocyte count and serum creatinine. The higher the ET lactate level, the higher it's associated with greater mortality in a broad cohort of admitted patients over age 65 years, regardless of the presence or absence of infection. And so that's why my 90-year-old got admitted. And this talk taught me that. Let's talk about procalcitonin and how interesting it will be. We have a question. Yes? The question was, did the patient end up having anything? Honestly, I'm back at Marlton today. I'll follow up today. I'll let you know. It's interesting. For me, when I'm working in the emergency department, age equals % chance of admission. So if you're 90, there's a 90% chance you're getting admitted. If you come in with a cut on your finger, okay. But if you come in with nausea, abdominal pain, fever, cough, I'll find out for you.
There's a podcast on abdominal pain and it said mortality rate for abdominal pain and the rate over 75 is 8%.
So what he's saying, I'm just going to repeat it for the camera, is patients over the age of 75, 80% mortality with the complaint of abdominal pain?
Yes.
Yeah.
So a lot of times people don't have abdominal pain until it's really severe.
Until it's severe, right. Now I did a CAT scan on this lady, but again, if I had caved, the admitting doctor didn't want her admitted. And we go through this all the time because everybody hates the emergency department. But sometimes you just have to stand your ground. If they want to come in and discharge the patient, then it's on them. All right, so procalcitonin, which is coming to an ER near you. It's been evaluated as a biomarker to assist the clinician in the diagnosis and treatment of bacterial infection. It's studied most thoroughly for lower respiratory tract infections like pneumonia and sepsis. Its use is associated with decreased antimicrobial usage without worsening of clinical outcomes. And we'll talk about what that means. What that means is if your procalcitonin level is normal, your patient probably doesn't need antibiotics, so you don't have to use them. Or if it starts at a high level and it decreases, that's the marker when you can start to taper your antibiotics down or maybe stop them. So what is procalcitonin? It's a 116 amino acid precursor of calcitonin, which under normal circumstances is produced by your thyroid C cells. Normal is less than 0.05. So that's a number that we're going to keep in mind. With systemic inflammation, particularly bacterial infection, your procalcitonin is produced in large quantities by many body tissues, including those thyroid C cells. This is really fascinating. Detectable within 2 to 4 hours and peaks within 6 to 24 hours. That's quick. It's not impaired by neutropenia or other immunosuppressive states, so that's really helpful. And the levels parallel the severity of the inflammatory insult or infection. So the higher your level, the more you're going to be worried about that patient. Maybe that patient now needs to go to step down or ICU as opposed to GMF or tele. What are the advantages? Specificity for bacterial infection. So if it's elevated, again, you're not blaming it on viral. It's bacterial, you're starting antibiotics. The rapidity of its rise after an initial insult, 2 to 4 hours, that's pretty good. Rapid decline with immune control on infection. So once you start your antibiotics and you repeat your procalcitonin the next day, it's helpful to see which way it's going. Are you on the right track? Excellent correlation with severity of illness. Again, the higher the level, the more severity. I guess the disadvantage, then, we're going to have to watch this and see, is it costs twice what a CRP costs. So if we're ordering calcitonin levels on every patient and multiple levels to monitor their progress, we'll have to see what the cost-benefit ratio is. Just really quickly here, not to bore you here. So there you have normal. Suspected lower respiratory tract infection. If it's 0.1 to 0.25, low likelihood for bacterial infection. Greater than 0.25, increased likelihood, start your antibiotics. For sepsis, you always want to treat your patient that's in front of you. If you're suspicious, you start antibiotics. You don't wait for your procalcitonin level to come back. But here's a test that maybe helps us. 0.1 to 0.5, low likelihood. Greater than 0.5, increased likelihood. And greater than 2, high risk, septic shock. Strongly encourage that you get those antibiotics on board. So really interesting stuff. You know, everything's always changing. This can help us. This can help us admit these patients that are on the fence. Going back to fever and infection, you always want to consider the possibility of other potentially serious causes of fever, which are present 10% of the time. Briefly mentioned some of these: rheumatologic disease, thyroid storm, environmental exposure, heat stroke, heat exhaustion, medication-related events, and malignancy. Try not to think those first, though. Although fever often signifies the presence of serious illness in elderly patients, severe infection may also be present in the absence of fever. The failure to mount a febrile response to infection has been particularly noted in nursing home patients. The most accurate definition of fever in the elderly may be a change in temperature from the patient's baseline. So specifically for these elderly patients, if they have a temperature of 99 or higher, or with an increase of 2 degrees Fahrenheit from baseline, they should be considered to be febrile. I don't know about you guys, but I always hate when patients, younger patients, tell me like their temperature's 98.9 and they tell you, well, my temperature always runs low. That's a fever for me. And I never really understand what that means. But in this case, in the elderly, it would be helpful to know what their baseline really is. And then if it's that degree or two higher, just to have your higher level of suspicion. Okay, this was question 2. This was the 91-year-old female from the nursing home, change in mental status, and we wanted to know which of the following organisms was least likely causing the infection in this patient. All right, nobody hit the wrong button. Let's see. Good job, proud of you guys. Right, no viral infections in the elderly. Not for this talk. Question 3, this was a 71-year-old male presenting with confusion, and we wanted to know which of those lab tests was associated with the greater mortality. Beautiful. Good job. All right. So let's talk about bacteremia and sepsis. Then we'll get into the big ones of pneumonia and UTI. The presence of bacteremia in elderly patients with infection signifies a more severe disease state and greater risk of mortality. Bloodstream infection is among the top 10 causes of death in elderly patients in the United States. Your risk factors. Why are we talking about it? Increasing age. Comorbid diseases. Almost all of the elderly have one of these. Diabetes, heart disease, neuropsychiatric disease, whether that's Parkinson's, dementia, malignancy, and stroke. Recent invasive procedure or instrumentation, and presence of indwelling catheters. Elderly patients with diabetes have twice the rate of bacteremia as those without. I think that we're pretty good at this also, but take note of that. Elderly patients plus diabetes, higher risk. Again, lower threshold to be thorough, lower threshold to admit and not get burned. Although fever is generally considered one of the cardinal signs of infection, numerous studies have demonstrated that an elevated temperature is often not present in elderly patients with bloodstream infection. So again, our role in the emergency department is hard. It's hard to convince an attending that a patient needs to be admitted without a fever, okay? These slides are now weapons in your arsenal that doesn't have to be there for them to have an infection. So therefore, as a result, the absence of fever cannot be taken as proof of the absence of bacteremia in this patient population. Be thorough, don't back down. The only independent predictors of bacteremia, so things that raise your level of suspicion when we see these patients in the emergency department. Altered mental status, that's every other patient that you see at Cherry Hill in Washington Township. Vomiting. I remember Dr. DiLeonardo at Cherry Hill when I was a resident telling me that vomiting in the elderly is always bad. Okay? It's not gastroenteritis. It's always something. And we talked about bands. Band forms greater than 6%. Wait for your differential. Elderly patients are likely to present with nonspecific signs and symptoms. We're going to again beat some themes here to death. Among the most common presenting symptoms of bacteremia, the altered mental status, confusion going hand in hand, weakness, falls we talked about, and decreases in functional status. I think you get that all the time around the holidays, especially Thanksgiving, Christmas. Family members come home and they say, oh, Granny's just not how she was. And it's kind of annoying because they haven't seen them in 6 months to a year. But do your due process in the ER. Don't blow it off. Laboratory testing fails to provide diagnostic certainty, so we know that. We know that their white blood cell count can be normal. Especially, here's a statistic right here, 20 to 45% will have a normal white blood cell count. Relying on an increase in the ESR is also insensitive for the diagnosis of bacteremia in the elderly. I don't know how many people are doing an ESR. I think that the CRPs replaced it for the most part, except in things like temporal arteritis or epidural abscess. It has great utilization for those two diagnoses. And again, we'll see where procalcitonin comes in. Etiology of bacteremia is heavily influenced by patient-specific factors. If you have an indwelling line, it's probably a skin source. If you have an indwelling Foley catheter, it's probably a urinary source. And if you have altered mental status with an impaired gag reflex, it's probably a pulmonary source. Urinary tract sources are the most common overall, even in the absence of indwelling urinary devices. They account for 25 to 55% of bacteremia in elderly patients presenting to the ED. I have to give credit to Washington Township. They're really good about this. The nurses know to straight cath every patient that comes in. Virtua, it's still a little painful. Bacteremia, lower respiratory infection, 10 to 34% of the cause. Sometimes it's just unknown in 11 to 31%. An intra-abdominal source, 9 to 20%. And a skin or catheter-related source, 9%. I think that one's important because I think a lot of times we think that cellulitis is lower on the list compared to UTI and pneumonia. But you just want to keep in mind that cellulitis can cause bacteremia and make patients overwhelmingly sick also. What are the organisms? It's a gram-negative organism 70% of the time, probably E. coli from their UTI. It's a gram-positive organism 25% of the time. Anaerobic, less than 10, but it's there. And polymicrobial, 5 to 17%. E. coli is the most commonly isolated organism. Your other causative gram-negative organisms are Klebsiella pneumonia and Pseudomonas. Your gram-positive organisms are Strep pneumo. We know about that one. Staph aureus. We'll talk about that, especially in related to influenza. Enterococcus and Strep viridans. All right, so let's talk about Staph aureus for a minute. The likelihood of Staph aureus bacteremia is increased in residents of long-term care facilities, particularly residents with nursing home-associated pneumonia or skin and soft tissue infections. It's less common in patients dwelling in the community. We're going to talk about this when we get to pneumonia specifically. It's important to differentiate community-acquired versus healthcare-associated, so we're sort of setting the stage. Last point to drive it home, bacteremia in the elderly is associated with high mortality rates. Overall rates have been 20 to 37% in most studies. Okay, so we're going to talk about pneumonia, and then we're going to talk about UTI, and then we're going to take a break, okay? Pneumonia. Pneumonia and influenza rank 6th among the leading causes of death. It's pretty high. With advanced age, rates of morbidity and mortality for pneumonia increase dramatically. Nearly half of all the cases of pneumonia involve patients greater than 65 years of age. And I think that's really funny because how many patients have you had in the ER tell you, but I got the pneumonia shot? All right, so yes, it helps, but obviously we diagnose these people with pneumonia all the time. Among nursing home residents specifically, pneumonia is the second most common cause of infection behind UTI. It's also the second most common cause of bacteremia in a nursing home. Several factors associated with the aging process of the respiratory tract and lung tissue predispose older people to respiratory infections. So as you age, you get changes in the mucociliary transport system associated with age. And then you have smoking that can also have a negative effect with clearing of bacterial pathogens. Because a lot of these elderly patients, they had a significant smoking history. They didn't know that cigarettes were bad when they were doing all the damage. Part of the aging process is you get changes in lung capacity, elasticity, and then the compliance. Most cases are in fact related to microaspiration of bacterial pathogens colonizing the oropharynx. Ineffective clearing of the mucus and secretions from the respiratory tract make patients more susceptible to aspiration pneumonia. Breaking down the different causes. So Streptococcus pneumoniae. Most common isolate from the sputum culture, 20 to 30% when you can get it. It's the most common pathogen found in nursing home residents. So again, it's important because you need to pick the right antibiotic. You have to pick your Levaquin or your Rocephin, your Zosyn or your Cefepime. Haemophilus influenza. Either the encapsulated H influenza type B or the unencapsulated strains. These are the patients that have chronic lung disease, but a lot of elderly have it. They have COPD, emphysema, chronic bronchitis. They're usually male. They usually present with a very productive cough. Legionella. These infections tend to occur sporadically. You usually see them in the summer and the fall when we start to turn on the air conditioning, so we're headed into a Legionella season. It may be found in the water condensed from air conditioning systems. So as we head into this, when you admit your patients for pneumonia, it's not uncommon for the attending to maybe ask you to do that Legionella antigen off of the urine. Mycoplasma. Common atypical pathogen causing pneumonia in patients under 60. Elderly patients have a somewhat lower proportion of cases of atypical infections compared with younger, healthier patients. So this isn't the most common one, but you can keep it in the back of your mind. Staph aureus, we talked about this briefly. It's most commonly associated with nosocomial infection. When you pull up a chest x-ray and you see multi-lobar infiltrates, that's probably Staph aureus. Frequently associated with bacteremia. And we'll hit this again. Well-known manifestation of Staph aureus infection is the florid onset of pneumonia following recovery from influenza. So this is another key point. During the flu season, when you have these patients that get better for a couple days and then come back worse, don't blame it on the flu again. That's probably their Staph aureus pneumonia. And it's important with Staph aureus because that's when you have to add your Vanco or your Zyvox to your antibiotic repertoire. Gram-negative bacilli, rare in younger patients, more likely to affect the elderly that we're talking about, nursing home residents compared with the community. Nearly 12% of pneumonias in patients from nursing homes are gram-negative. Classically, cough, especially productive cough, and fever are the hallmarks of respiratory tract infections. Other clinical manifestations may include pleurisy and rigors. In the elderly patient, the clinical presentation is similar. However, the rates of patients presenting with these manifestations change. Although nearly 60% of patients with community-acquired pneumonia presented with cough, only 34% of nursing home patients were noted to have a cough in the setting of pneumonia. So now we're starting to separate out our elderly that are living in their homes versus the elderly living in nursing homes. Then you get more confounding for the picture, the fact that only 60 to 75% of nursing home patients are febrile. What's your initial workup going to be? Pulse ox, chest x-ray, CBC with diff, blood cultures, serum electrolytes including a BUN. For me, it's definitely a lactate right now, and we'll see over the next couple weeks to months if it's a procalcitonin. Your chest radiograph remains the gold standard for diagnosing pneumonia. Serum chemistries have little impact on patient outcome. However, calculation of creatinine clearance may influence your choice and dose of antibiotic therapy. I think we had talked about this before. You guys are actually starting to write orders, some temporary orders at Kennedy now. It is actually important to know what their creatinine clearance is if you're going to write for Zosyn to be continued or Levaquin that you're renally dosing it. So that's where it comes into play. We're going to talk about community-acquired pneumonia now, and then we'll talk about healthcare pneumonia. The etiology of community-acquired pneumonia is similar to that in young patients. Strep pneumo is the most common etiologic agent, accounting for about half of your cases. Haemophilus and Moraxella are also relatively common. So these are the patients that are getting Rocephin plus Zithromax or Levaquin. Atypical agents such as chlamydia pneumonia, mycoplasma, and Legionella are seen in approximately 15% in the community-dwelling elderly patients, lesser percentage than in the younger patients. Your Levaquin, your Rocephin, Zithromax will cover these as well. Enteric gram-negative rods and Staph aureus are rarer pathogens and are more likely to be seen in the most severely ill patients. Community-acquired pneumonia developing after viral influenza has an increased chance of being Staph aureus. Again, driving that home because now you have Rocephin, Zithromax plus Vanco, Levaquin plus Vanco. Nursing home and other healthcare-associated pneumonias. It's important for us to differentiate this. If you make the diagnosis, you have to pick the right treatment. Otherwise, it's not that helpful. Okay? It's distinguished. They're two separate entities. Healthcare, nursing home acquired pneumonia. It's associated with increased comorbidity, poorer functional status, and greater mortality. The mortality rate's 19 to 53% as compared with 8 to 14%. Those numbers are a broad range because it depends on the different articles that you read, but just driving home the point that it's more serious. So what qualifies you for hospital or healthcare acquired pneumonia? Hospital-acquired pneumonia is pneumonia that's not present on admission that develops 48 hours or more after hospitalization. Ventilator-associated pneumonia, again, not present on admission, but it occurs 48 to 72 hours after endotracheal intubation. Just healthcare-associated pneumonia, so you have to have one of the following. You have to reside in a nursing home or long-term care facility. You've gotten intravenous antibiotics, chemotherapy, or wound care within the preceding 30 days. You've had hospitalization in an acute care setting for 2 or more days in the preceding 90 days. Or you've had attendance at a hemodialysis clinic, you're a dialysis patient. I think that points 2 and 3 on there. Just look at those for a second because that's part of our history taking. If you don't ask those questions, you're not going to get that history. And you have to be pretty specific because patients don't know. They're not sure. They don't know that that little pill that they take is actually their chemo for their multiple myeloma. They don't remember 90 days ago that they were admitted. Try to focus on that because now you're switching your antibiotics to Zosyn, Levaquin, Cefepime, Levaquin, plus or minus your Vanco. With healthcare-associated pneumonia, strep pneumonia is still the most common organism. However, enteric gram-negative rods, anaerobes, and Staph aureus are much more common. And then you have your Pseudomonas rates that have been 4 to 25%, but as high as 52%. And that's where we switch to the Zosyn and the Cefepime. Haemophilus influenza, Moraxella, Chlamydia pneumoniae, and atypical agents are much rarer than in the community-dwelling population. So we're not really thinking those for the healthcare-associated pneumonia. Now that we distinguish the difference, we'll talk about the treatment, which I hit. So we're going back to community-acquired pneumonia right now. Second-generation cephalosporin plus a macrolide, right, your Rocephin, Zithromax. Non-pseudomonal cephalosporin plus a macrolide. Well, that's actually your Rocephin, Zithromax there. I don't even know if we have a second-generation one at Kennedy. Do you guys? Nobody writes for it, right? Monotherapy with a fluoroquinolone. Treatment for your nursing home. Ideally, 2 drugs for gram-negative coverage, as well as a drug for MRSA. So again, your Zosyn, your Cefepime, Levaquin, Vanco. If they're allergic to penicillin, then you have to go with your Azactam. So your second gram-negative drug can be, so I keep saying Levaquin, you can keep in mind that you can use an aminoglycoside as well. So if they're quinolone allergic, Cipro or Levaquin, use your gentamicin or your tobramycin or your amikacin. You have to make sure that you renally dose that one in the ER. Okay, you can actually do a lot of damage if you don't renally dose that one in the ER. Okay, usually it's 1 mg per kg divided 3 times a day. And then if MRSA is a concern, you're going to add your Vanco or your Zyvox. All right, home stretch. Urinary tract infection. This is the one that we most commonly see. So we're going to spend less time, we're going to spend some time on it, but it'll be shorter than the pneumonia part. So your urinary tract infections encompass a spectrum of disease from asymptomatic bacteria and cystitis to pyelonephritis and urosepsis. I think, we sort of get into trouble with that in the ER. When is it really just asymptomatic bacteria versus a real infection? I think from our standpoint, it's not really up to us to figure it out. If you have a dirty urine, a contaminated urine, start them on antibiotics and admit them. Let somebody else make that decision. These are the most common infections affecting the elderly. Among otherwise healthy geriatric patients living in the community, rates of UTI range from 5 to 30%, with higher rates seen with advanced age. Among institutionalized patients, the prevalence rates increase remarkably, between 17 to 55% of women and 15 to 31% of men. Anatomic variations during the aging process increase the risk of UTIs. So again, hitting home just how aging increases your risk. You have changes in prostate function in men, changes in vaginal flora in women associated with menopause. Elderly patients are also more likely to have obstructive uropathy or anatomic changes related to childbirth or reproductive surgery. Other factors to consider: higher rates of incontinence, more frequent urologic instrumentation, higher rates of catheterization, comorbid diseases, which they all have, and medications that alter bladder function. Among young, healthy patients, the vast majority of UTIs are a result of E. coli, Proteus, Klebsiella, Enterococcus, Pseudomonas, and Staphylococcus species. Elderly patients have a lower incidence of E. coli infection and higher rates of polymicrobial infection. So that's important that we're going to talk about. It's getting to the point where if you have somebody, an elderly patient with a UTI in your emergency department that's sicker, that one antibiotic's not enough. Since it's a polymicrobial infection, we need to be treating them with 2 antibiotics. Patients with short-term urinary catheters are typically infected by a single organism, while long-term catheters are associated with these polymicrobial infections. Then we have the prevalence of gram-positive UTIs in geriatric patients that have been increasing, and that's your Enterococcus infection that we're seeing. Sometimes it's sensitive to everything, but sometimes it's actually the vancomycin-resistant Enterococcus that we're seeing also. Again, atypical symptoms. They're not going to tell you that they have dysuria, urgency, frequency, flank pain, the common things. They're going to tell you that they have malaise, they're not eating, they're weak, or the subtle mental status changes. Often delirium and functional decline are the first signs of bacteremia from a urologic source. These non-urinary symptoms are more likely to occur in patients with existing comorbidities, and that includes dehydration. Urine microscopy and culture make the ultimate diagnosis. We know that. We get the UA and the ER. Obviously, you're not going to get the culture. It is helpful, though, if they've been admitted in the past, to look up previous cultures and try to pick an antibiotic that's been sensitive in the past. And I do that. Now that we were talking about Ibex and Saurian crossing over directly to the patient, it's not that much extra time to look up their old culture. Okay, so talking about treatment, and I briefly touched on this, we actually want to do broad antibiotic coverage for a longer duration. That's really going to be the cornerstone of our treatment plan in the elderly. Bigger drugs, longer time frame. This isn't the Bactrim or the Cipro for 3 days in these patients. Really, you want 7 to 10 days of treatment. That's preferred for women who have had symptoms for longer than a week, women with structural or functional changes, and for all men. So all men are getting at least 7 to 10 days. 14 days of treatment should be routine for elderly patients with pyelonephritis. Okay, so probably to be safe, you're thinking in your head 10 to 14 days. It's not usually up to us, but if you're sending somebody home, longer. Treatment of uncomplicated community-acquired UTI in the elderly is generally with a fluoroquinolone, so Cipro, Levaquin, Macrodan can be included here. Due to the increased rates of resistance, Bactrim is not preferred as an empiric first-line agent. Okay, so again, we're talking about elderly patients. Stay away from your Bactrim, more towards your quinolones. It can be given to elderly women when the sensitivities are confirmed that it's sensitive, but there's a higher incidence of side effects and discontinuation when compared with the fluoroquinolones. So in this population, go with your fluoroquinolone if they're not allergic. Talking about intravenous antibiotic therapies for the people that we're admitting, a fluoroquinolone, you can do gentamicin plus or minus ampicillin. You can also do a third generation cephalosporin plus or minus an aminoglycoside. So I've been kind of doing a combination of this whole slide. A lot of times I'm doing Rosefin plus a fluoroquinolone, or I'm doing Rosefin plus gentamicin. Double coverage. Selecting the optimum treatment for UTIs acquired in a long-term care facility or in the presence of other complicating factors is more difficult due to the high prevalence of resistant organisms. Again, fluoroquinolones first line, cautious to use it as monotherapy, less preferred than combo therapy. All right, so take this away, practice this from here on out. Complicated UTIs, 2 drugs started in the emergency department. Okay, again, aminoglycoside plus or minus ampicillin, anti-pseudomonal beta-lactams, that's your Zosyn, anti-pseudomonal carbapenem, that's your cefepime. Patients who have an increased risk of drug-resistant organism or who are moderately to severely ill, strongly considered for the 2-drug therapy. And again, if you have a chronic indwelling catheter, you want to consider replacing the catheter in the emergency department, actually. I always just make sure before I do that there's no history of having trouble inserting it. There's nothing worse with taking out a catheter, especially in the men, because you think that you're doing good and then you can't get one in at all. But these patients who come in with their chronic indwelling Foleys from their nursing homes, you do want to try to change it in the emergency department and then get a fresh specimen. So to summarize part 1, evaluation and management of the elderly patient with infection in the emergency department presents several challenges to us as emergency medicine physicians. Elderly patients often present without classic signs and symptoms of infection, requiring vigilance in the face of nonspecific symptoms such as confusion or decreased functional status. These patients are at higher risk of poor outcomes than our younger adults. They are also at greater risk of infection with resistant organisms, necessitating the empiric use of broad-spectrum antimicrobial agents. So you can get the nice, happy geriatric couple in the picture by considering all of these unique aspects of the infective elderly patient. It will aid us in providing optimal care to this at-risk patient population. And that is it for part 1. Thanks for hanging with me.